Hello everyone, it's time for our Hangout on Air discussing Ebola containment options, which includes isolation, education, and some other things. So we have a really exciting topic to talk about, and we've had quite an ordeal trying to get our guests in, and I'll tell you why in a minute, but I'm going to introduce them all in case one has to drop out and come back. So I'd like to first introduce Stephen Callens. Dr. Stephen Callens is an infectious disease specialist and World Health Organization doctor from Belgium. Would you like to say hello, Dr. Stevens? You might have to unmute yourself in order to say hello.
Okay, hello everybody. I'm talking from a train, so I might drop out.
And we're expecting you to probably have to drop out very soon and then come back and join us. Can you tell everybody a little bit about your background and your experience here?
So I'm an infectious diseases specialist. I work in Belgium now, but I have experience in Africa. I worked at the beginning of the HIV epidemic in Kenya, then worked with tuberculosis and HIV in Congo, and worked in Ebola outbreak in Congo Brazzaville.
Thank you, Dr. Callens. The next guest that I'd like to introduce is Randy Roberson. He is no stranger to my healthcare hangouts. He is a Senior Disaster Management and Risk Reduction Telemedicine Specialist and World Leader in Disaster Response, and he's from the US. I'd like to introduce him. Randy, would you like to say hello?
Sure. Hello. Glad to be here with you again today, and certainly a great topic talking about Ebola.
And I'm glad you can join us. Can you tell us a little bit about your background?
Right. Well, I've been doing disaster response work since 1998, primarily focused on mobile medical clinic deployment in disasters, especially in the early hours during the medical surge, and then sustaining that through the relief and redevelopment phases of disasters. This has taken me now to roughly about 35 countries, and has most of that was done on the nonprofit side, actually kind of reinventing the term nonprofit. But I've also been doing a lot of consulting work for worked on a significant national telemedicine network project last year in Romania through a US TDA funded project there, and then also doing consulting work currently for NATO as it pertains to the use of telemedicine and disaster response, and I have a number of different things going on right now as it pertains to Ebola, and just finished facilitating a think tank of some significant thought leaders on the subject this last week, so bring a few of those thoughts with me today.
And we look forward to hearing about those. The next guest I would like to introduce is Dr. Ludwig van Boxelaer. He is a primary care physician and physician advisor of several organizations in Belgium. And Dr. van Boxelaer has focus in risk reduction, and he asked me to hold this conversation, so I'd like to now pass it to him. And Dr. van Boxelaer, can you please say hello and introduce yourself?
Hello, I'm Ludwig. Van Boxelaer is a little bit difficult. I'm very happy to be here, and I want to thank especially the other members who joined this great conversation.
Thank you. So we're going to get started here, and I'll give you a little background, those of you who are watching live. We're probably going to lose Dr. Callens, and he'll come right back in. He was delayed by a subway fire in Belgium, in Brussels. So we're just lucky to have him be able to join us at the beginning so I can introduce him. And if we lose him because he's still traveling home, rest assured he's going to join us. We also had a couple of other guests that may be coming in late. We have, I won't even name them because I don't want to put them on the spot, but we have some that are physicians on call and in transit, and some other people that we're not sure if they'll join us late. So we're going to start this conversation. And where would you like to start, Ludwig? What would your opening question or topic be for us to begin?
I think the first thing we have to know is this something for everyone or simple for specialists? Normally, when you have a disease, doctors are aware of the problems, but the fear is for the patient. And how can we help them in their field?
So are you asking if our audience, about their audience that is watching today, or are you asking about something else? Let me clarify.
No, I'm asking it from the doctors in this panel, and how that they think what has to be done that people can be aware of the training and the acceptance of the isolation.
Okay. Did you all understand what he's asking? I'm going to fill in the blanks a little bit, and you tell me if I'm wrong, Ludwig, since we've had some of these discussions in the background. One of the things that Ludwig was proposing was that not only is isolation by itself something to consider, but along with isolation, since it's so hard to enforce, that maybe a better approach is also a combination of isolation or self-imposed isolation by educating not only the public that might have to be isolated, but the public, the loved ones around those people who are isolated, to help reinforce proper protocol of self-isolation. Did I get that right?
Correct.
And so let's start with that discussion. Would someone like to chime in and talk about the viability of enforced isolation versus self-imposed, what's happened so far, and some of the observations with what we know thus far?
Well, I'm happy to chime in a little bit here in that again, pointing back to the think tank that I was involved with this past week, I think a lot of the dialogue there was focused on two separate realms of response. One here domestically in the United States, and another one more of a source-based focus in Western Africa. And certainly, a lot of interesting dialogue on the containment there as far as international travel coming out of those places. Not necessarily travel bans, but much more careful analysis of who's getting on flights and their condition and that type of thing. Domestically, a lot of well, a couple of quick points. Domestically, one of the things, a great, for instance, that happened in the community where I live here in central Arizona. I'm about an hour north of Phoenix in a rural area, and one of the gentlemen that traveled with me to the Philippines last year for the super typhoon relief effort there had recently been over in Western Africa, and and was very, exceedingly disciplined in contact with others. Definitely did his homework. Didn't really have a problem. Came back to the United States, but because of a lot of the media hype and a kind of alarmist information that was coming out of some of that, it became a very a volatile environment here for him, with people just afraid that him just being in the community, everybody was going to die from Ebola. So there's a few different things to address there, but all of that said, a lot of dialogue came up from this as far as this gentleman did home quarantine himself and his family for 21 days after arriving back home. Again, I think that more attention needs to be given on the source side of things before they come back to the United States, and there's a lot that could be talked about there. But on the home monitoring front, with so many different telehealth apps for smartphones and things like that, and for computers that are available now, there's with minor modifications, so many things that could be done for not only providing home monitoring information and guidance, but also a chance for doctors to be monitoring routinely the fever and different elements like that. So there's a lot more that can be done on the home monitoring end that has been being done. But I believe that both of these concerns are critical. I think the containment, especially at this point where we're at with this outbreak, is perhaps a little more of a significant focus, or should have a little bit more of a significant focus in Western Africa, whereas here in the United States, I think the home containment idea is something that we need to look at a lot more. But there's there's still many other topics, and I won't go too much longer on this particular thing, but there's a lot more to be talked about as far as how local hospitals are handling these various infectious disease bugs that come to their front doors, and how to keep those from infecting other hospital populations.
All of you, just so you know, if you can go ahead and unmute so you can join the conversation spontaneously. You don't have to wait for me to call on you. I do want to just send a shout out to Mark Tannenbaum, because that is one of the comments that he made on the event page, Randy, so I'm sure he's excited that you're bringing up the idea of the mobile health apps and people remotely checking in on people. Oh, it looks like we've lost Stephen, and he'll come back shortly. So let's talk a little bit more about the mobile health apps as a portion of isolation, or the alternative of self-monitoring. What kind of apps, for example, do you know of, and do you think the general public would be able to use them and know about them?
You know, personally, there's been many that have come out onto the market, and because I deal in telemedicine on a regular and for many different projects, I do a lot of consulting work for government and for private corporations. I have purposely kept myself vendor neutral so that we can move and adjust on a mission-specific basis as far as the systems and tools, peripheral devices, things like that we need. So that said, I don't really have a specific one to point to. I also believe that we're kind of in the early stages of development and refinement in a lot of these. So I don't have a particular one to point to. I just know that the technology is there where even with things like a wearable devices that can be set to software that triggers that if a fever goes more than, you know, say 99.9 or whatever you would preset it at, that it would automatically trigger a message to the physician, as opposed to you know, the warm fuzzy do-it-yourself home app where people can kind of self-monitor. I think maybe there's two different sets of things to look at there. The self-monitoring where people can be keeping track of information themselves, and that's all good. But then I think there might be some instances where in many different realms that there are compliance issues, whether you have someone who, you know, maybe the elderly with mild dementia and things like that, who might not remember that, hey, I'm not feeling good, that's right, I was supposed to call my doctor and tell them that. There's many different automatic devices that can help facilitate that. All of that said, I guess the much shorter answer than all of that for you would have been, I don't know of one particular one that I would recommend. I just know that there's a lot out there, and it wouldn't be hard to find something that, with slight modification, you know, could be perfect for this kind of challenge.
Well, I know that we have a lot of the wearable, like the wearable watches that have come out, even the, is it called Wii Fit, or, I mean, that's just an example of one, but the things that you would wear naturally as you would wear any other clothing could monitor temperature, pulse, things like that on a regular basis, where we know that in the past the doctors and nurses that have come back and then later been asked to be in isolation and in some cases have fallen ill have at some point been out in public and later became ill, and the question became, well, when exactly did they break the fever? When exactly were they contagious? And having something that would automatically monitor something like that would give a very good timestamp of when that happened. Am I right?
I think so. I'm sorry, go ahead there.
I agree that self-monitoring automatically should be the future, but now I don't think we need this at this moment. I think the first thing we need is that patients communicate with doctors digital, and by something like Hangouts or something else, by video calls, but they need to start with this. And that's the most difficult thing. Getting people on their cell phone and talk with their doctor or their caregiver about their diseases, their fear, their wishes. Not only go to a waiting room. No, take your cell phone and talk with them. When patients don't try to do this, doctors will not do this. Well, there is no demand There will no be an answer.
You know, and I think it's interesting. I think along with that, you know, as far as those wearable devices, one place where that might be really applicable now, and I would tend to agree. Perhaps the wearable devices, not that maybe not that significantly significant domestically as far as home containment, but certainly when it comes to, again, kind of turning back towards that source-based focus on confining the outbreak to its source location. One of the challenges that I know I've seen, having traveled internationally quite a bit, is that well, as a quick for instance, flying from Kennedy International in New York to Johannesburg, South Africa, you can be in a 747 for 18 and a half hours nonstop. Prior to doing that, I didn't even realize those birds could stay in the air that long. But that said, you could be boarding that plane feeling perfectly fine, and nothing is troubling you at all. But over the course of that 18 and a half hour flight, or a 12-hour flight, or whatever it happens to be, depending on where you're going, perhaps there should be I don't know, one of those wearable thermostats on your forehead or something, or thermometers rather, that shows that during that that flight, if all of a sudden you start running a fever, the people on board that flight can take some kind of precaution. I have no idea what the precaution would be at that point. Obviously, to me, probably not a real popular focus by a lot of folks, for a lot of folks, but I think basically if doing humanitarian aid like I do, if I'm going into an infectious disease area, I need to automatically just calculate into my trip the fact that whatever the incubation period is, and that's a whole other interesting area to discuss in more detail at some point someday. But whether it's 21 days or 3 days or whatever, I need to factor in that I need to sit somewhere and quarantine myself that long before I hop on and potentially infect people on the plane, and furthermore, before I come home and infect my family. And I know there's some people that think that that's terrible and no one should, there's no way you can enforce that kind of thing. Well, I think that as far as true containment, that's the only way you can really do an effective job, in my opinion. So, I think that some of these wearable devices, though, might be good in those transition areas where you're maybe transiting from one place to another and needing to be monitored over the course of a number of hours or something like that. But there are many different ways that you could customize some of these approaches depending on what the problem is and where the problem is.
I think that the test has to be simple. You don't need so many figures. There is no exact high level of temperature. It's simply a rise of temperature with 1 degree that you have to look at. And it's different for every people, and it's different for every product that you use for testing. You have to know your own product, and you have to do it, so you have to train it. If it's digital or not, that's not the point. You have to test yourself 3 times a day. That should be a normal way of doing things. It's like washing for yourself or wash your teeth. When it's about your weight, that's normal. Everyone does this. But for your temperature, no, it's too difficult. And it's not. But what I want to try to say is the connection between doctors and patients is not on a regular basis. It's not something you do easy. You have to be the doctor has to be there, you have to make an appointment. It's very difficult. And I want to facilitate this. Normally, a doctor should be allowed to do 1 hour a day of consultations for free, or it can be paid by the government, simply looking at the people with questions by mail or by hangout, so they can isolate themselves. And then it's more easy when you have a contact with your caregiver to isolate it. When you have to do this all alone, that's not so easy.
I think it's worth mentioning that we are talking about different countries here. We're not just focused on the United States or Belgium or West Africa or any other place. We're talking about a lot of different countries, and at least in the United States, I know one of the concerns is how expensive it is potentially to treat patients. And so when you start talking about the difference between having a patient walk into the ER and say, I think I have Ebola, versus doing some kind of virtual consultation to decide whether or not that isolation needs to happen proactively, is a real big money saver, at least in the US. I don't know about the reimbursement process and the expenses and everything in the other countries, but I would think that would be the same across the board, yes?
That's correct. You can save money by using video calls. And it's happening, but it's happening too slow and too little. Ebola can help, and we need to help each other to win this war of Ebola. And I think we have to use our brains and our computers for this.
Randy, since you have experience with telemedicine in general, is there a viable way to be reimbursed for telemedicine conferences like this? Because I know that's always the question doctors in my network ask is, well, we don't get paid for that. We get paid for an office visit.
Yeah, well, as far as that's first of all, it varies from state to state. But the American Telemedicine Association has been doing a lot more lobbying along those lines, and as such, yeah, there are. I know here in Arizona, been involved in a number of projects where if you as a patient were to come into my office, if I was a physician for you, I could, and you needed to talk to another specialist, I could facilitate a telemedicine call to another specialist, and that specialist would get paid and I would get paid. So there are ways of doing that. It varies from state to state, and I think there's many different variables there, so there's not really a one answer fits everything on that, but more and more telemedicine is becoming a viable tool. Likewise, if I was had some type of infectious disease and was staying at home and was connecting to you, my physician, as or via a telemedicine connection, that is billable as well. So there is more and more that's happening that way, but it varies a lot from state to state. But in just the last 2 years, a lot of changes have taken place that way. So I'm very optimistic about the direction that's headed. Likewise, in emergency response disasters, there's been lobbying successfully done that relaxes the border constraints so that a physician here in Arizona could, during a time of disaster, say treat a victim, some type of trauma victim, or see them and consult with them in like a hurricane down in the New Orleans coast. And I don't have to worry about not being licensed in that state, don't have to worry about the malpractice insurance things. A lot of that is relaxed during times of disaster. More and more of that is happening. The Avera people up out of South Dakota, their telemedicine efforts, I think, go out to 4 or 5 different states. So there's, and again, all of that is billable stuff. So more and more it's happening. We're still in the early stages of people have learned how to spell telemedicine. Some states are still learning how to use that in a complete sentence, but we're getting there.
And I know that there are some companies, and we won't list the companies, but there are some companies that offer that service to hospital systems, for example, and they work in coordination with that local hospital to provide the virtual services. And it's kind of like you say, they pair up with the physicians of that system so that there's a state licensed physician relationship, and they provide the telemedicine. So there are some options where you can have those arrangements in that.
Sure, and as a matter of fact, a lot of that's been done variations on that theme have been done for quite a while, where hospitals overnight often had been using a radiology company in India, because they're, it's daytime there when it's nighttime here, and so they're reviewing radiological imagery in the middle of the night our time. And as such, that's all billable, but they're not waking up the local radiologists to review those. So there's been variations on this theme that have been done for a while. It's just being done more and more widely, and actually that's accelerating significantly.
Mm-hmm. And is it possible that we can follow the consultations of the doctors in Africa? That is our laboratory for how do you treat the patients with Ebola?
Sure, and so much of the international telemedicine. Go ahead.
Is there already telemedicine in Africa or not in this Ebola situation?
In most of the areas that I'm familiar with, the bandwidth, and for those of you that are not familiar with that, the internet signal speed is not that great. As such, and a lot of different things come under the heading of telemedicine. Rather than a live video, audio telemedicine consultation, kind of like what we're doing here, they end up only being able to do more like store and forward telemedicine, where it's a matter of typing out some questions on an email, maybe having a photo attachment to that email and sending it. I've not seen a whole lot yet going on as far as the use of telemedicine in that, as far as the Ebola thing, but have very much been involved in the use of telemedicine in some other developing countries for not only specialist reach back, but also for training of surgeons. I know the Grossman Burn Centers in LA and their Grossman Burn Foundation. I've worked with them for a number of years and working to use telemedicine to train surgeons in Afghanistan and also in Indonesia with the latest techniques in reconstructive burn surgery and stuff like that, so they can be used to not only monitor a patient, but also help educate with some of the latest techniques using these telemedicine connections. The biggest problem is so many of the developing countries have such poor bandwidth. It's difficult to get high quality connections, but more and more that's changing. Just a few years ago in India, it was almost impossible to do telemedicine, except for going via satellite, which is really expensive. Now their communications infrastructure has been bolstered so well that 3G and 4G cellular signals are very easy to come by, even out in a lot of the rural areas. So a smartphone, like one of our colleagues was using here a moment ago on the train, a smartphone can work wonders in telemedicine without all the cumbersome other computer setup. So a lot can be done. I guess the big point though is currently with the Ebola thing, I don't think telemedicine is being used there that much currently. That at least none that I'm aware of at this point.
And the American Army doesn't use it?
American military, TATRIC is the acronym for it. They have a very significant telemedicine arm, and really most of the technical development of new peripheral devices and things like that, most of the development of that has come out of TATRIC and their funding. So I do, the short answer is yes, the U.S. military does use telemedicine significantly. I think where perhaps the breakdown might come relative to our teams, our military teams being deployed into West Africa, is there's much less of a need for that telemedicine reach back. If you have a highly trained physician from, say, the United States that's deployed there, he doesn't really have a big need to reach back to other physicians here in the United States because he's there on the ground and can handle most everything on his own. Whereas if you're out in some of these more austere areas where that kind of capability isn't there, then these telemedicine connections are far more critical. And very quickly, just to put some icing on that cake, a lot of what we do in disasters is just that. We're out in the field Haiti is a great, for instance, after the earthquake there, with a lot of crushed arms, crushed legs, amputations that are needing to be done, and most of the people on the ground there are EMTs or paramedics, and that's way beyond their scope of training to do those kind of procedures. So having doctors looking over their shoulder with a telemedicine connection can have a profound force multiplier positive impact. But again, I think right now with our teams going over there, they already have pretty much all the capabilities and training, so there's a lot less of a need for a doctor to reach back to another doctor, as opposed to perhaps a highly trained developed country doctor reaching back to another one isn't as significant as perhaps a lesser trained doctor.
I'm asking this because in my country, surgeons use telemedicine to educate other surgeons in other countries. They don't need them, but they can teach them. And Africa can teach us, European doctors, how to treat Ebola. And when you need bandwidth, the American army is there to give them bandwidth. It's simpler than give them doctors. They need doctors, but they can't use the time for education. We need education. We think we know Ebola. I don't think we know it. We don't know what the isolation is, how you can survive isolation. Because you have to know the acceptance of fear. You can't shoot on people to isolate them. You have to convince them, and how you convince people to do the right thing. You have the same problem in America.
Sure. Yeah, that's one of the big topics that came out of this think tank on Ebola that I was involved with this last week. And again, we had people involved in this that were from the U.S. State Department, the CDC, some significant thought leaders on the subject. But one of the big concerns that was raised was the fact that we need to be much more effective in how we communicate with the public and deal with the media, so that we don't have the perpetuation of some of this fear mongering that has taken place. And certainly I agree with you. I don't think we understand everything we know about Ebola yet, but we do understand a fair amount. And unfortunately, even the things that we knew quite well, we weren't communicating very well. And that breaks down even to our, in my opinion, and in the opinion of some of the others that were involved in this other think tank, it boils down to we are very prepared in the United States in many places when it comes to disaster response, whether it's like an earthquake or a flood or whatever, how we're going to deal with that medical surge, things like that. We're fairly well prepared. I think Japan really leads the way on their preparedness that way. But nonetheless, we really, though, have kind of dropped the ball when it comes to infectious disease, in my opinion, in that I think that we it's easy to get lulled into that false sense of security that, oh, those things only happen in distant countries, and really it's probably only a matter of time until another strange strain of flu or Ebola or something comes in and wipes out vast populations. And we saw in the United States that many hospitals weren't equipped to even how to deal with a patient coming in with a serious infectious disease. There wasn't proper training when it came to the donning and doffing of emergency gear, things like that, and so there's a lot more that needs to be done. But again, one of the big topics that came out of that whole discussion was that it's probably not realistic to look at every hospital being able to adequately address these concerns. We really need to set up either a regional hospital, or like in a large metropolitan area, have one hospital designated as the place to go if you have an infectious disease problem. But you still, at the other hospitals, there still needs to be a way to stop this infectious disease patient at the door and get them safely transported to where they need to be. And I can drive into that subject in a lot more depth, but that was one of the other big concerns that was being talked about as well. And I just think that preparedness-wise, bottom line is I think we can do a much better job. We need to admit it.
Donning and doffing is a good example. I have grandchildren, and the first thing we learn with grandchildren is to tie their shoes. It's something very easy. Even doctors and nurses don't know how to do it. It's crazy. But it's because they say it's for someone else. When you show Africa by telemedicine, when you give them the benefits that the American army has, you can convince doctors, you can convince people to learn Davi. It's not easy, it's simple, but you have to do it. You don't have to wait till in 3 years when we really will need it. We have to train it now. It's like my job as an occupational medical doctor. We have to train people for disasters. You can't give a fire training after the fire. You have to do it before and several times. And I don't see training. I don't see the beliefs in training. Yes, the beliefs in training of what one team of nurses and doctors in one hospital. No, everyone just has to know this, like my grandchildren know to tie their shoes.
I'd like to expand on both of your comments here, because as I'm listening to both what you've been saying, I've been putting two and two together here, and with Ludwig mentioning that there is a certain familiarity that West Africa has with Ebola because of the long time that they've been dealing with it, and yet they don't really have the medical means that we have, for example, in the United States. But when it comes right down to it, the problems we've had with our cases in the US have been with medical workers who are well informed. The problem was that they weren't well experienced with dealing with a patient who came in with Ebola and then handling them, as Ludwig said. Would it not be smart to use something like this telecommunication tool so that I know that one of the protocols now is that when a healthcare worker is suiting up, they're supposed to be witnessed by someone else, kind of as a checklist, to make sure that that person is suiting up properly. But if that person who's witnessing is also not familiar with the process, then there's room for error. But would it not make sense that the telecommunication tools would be useful here, not only in the cost by being able to tap into someone in another country who has more experience, but the fact that they do have more experience to be able to have people there that witness nothing but suiting up and suiting up and suiting up and suiting up and seeing when there's something not done right, that could be an efficiency that would both save money and improve the quality of that suiting up.
Yes, I would like to see it. And it's like in the army. You learn it, you train it, and you become a chief. And that chief will look at the other, and every time you give someone a higher level of coaching other people, and we have to film it and look, this is something we can do, and no, there were losing time. It's like a game. You can, and I think you don't have to create fear about this, but you have to create the willing of fighting against something you can fight against. You can fight against infection. It has taken a lot of years before doctors understood that you have to wash your hands before surgery. I think we have to learn it much more faster to our doctors and more to our people, because patients don't need to understand this, that this is important.
You know, and I think too, Ludwig, I agree with you, and I think tying back to something that you said earlier, and this is not only true with infectious disease, but it's true with emergency or disaster response in general. One of the biggest challenges that those of us that work in that world face is that the only time we really have everybody's attention is right in the middle of when everything, and frankly, is hitting the fan. When we're right in the middle of a disaster, then all of a sudden everybody wants to they want the information, and they you know, we got to get better training and we got to do a better job, and everybody's on board with that. But as soon as this, for instance, this infectious disease outbreak, as soon as it wanes further, and I believe it will, but as soon as it does, man, it's amazing what a short memory and a short attention span we have, and we go back very quickly to you know, this only happens in other places, and it won't happen here again for a long time. We don't have to worry about it now, or you know, this complacency sets in, and you know, for something as simple as the donning and doffing stuff that we've been talking about here, there is a lot of attention to detail, and it is a two-person operation. CDC, as a matter of fact, some of the stuff that I posted up under the chat window here just a little bit ago, you'll find some links there that from this other think tank. I believe there's some links in there to the CDC video, training video for donning and doffing equipment. You know, and there are some that would say, well, there needs to be more information there, or whatever. But still, I mean, there are a lot of great training mechanisms out there and materials, but you know, they weren't being implemented in many of the hospitals because we, you know, kind of fall into this complacency of thinking these things only happen other places, and it absolutely can't be this way. We have to take a more proactive approach to this, and we have to continue to pay attention before the next really big one comes along. I mean, even our nonprofits that the World Vision, Samaritan's Purse, other groups like that, they'll all tell you that their ability to raise funds is significant while the media is paying attention to a disaster. They can raise funds for that disaster. As soon as excuse me, as soon as the media stops paying attention, their ability to raise funds plummets. And so, that said, I think my point here is that we need to find a more proactive way to work with the media and be feeding them the information that is of interest to them to share with the public. But we need to get better at the way we communicate these needs so that we can be more well prepared, because every single time it seems like we just fall back into a place of complacency, and that doesn't serve any of us well.
Well, let's take this conversation back to where we were going to start, and we kind of went around the barn, but we're talking about education, because education is a form of addressing complacency, to be able to have a very good familiarity with the proper protocol, the proper steps, not only from the public perspective, but from a healthcare worker perspective. So what efforts could we employ that would educate either workers? I know that there are some training programs that are now being mandatory in the health systems, but what else could we do to first educate the healthcare professionals, and secondly, as Ludwig suggested before, to educate the public so that when someone is thought to possibly be carrying Ebola, that the people around them help them follow the right steps to stay in isolation. And I see Stephen is joining us again here, so he'll be in on this conversation as well. Stephen, I just posed the question about education, trying to deal with the complacency that Randy was discussing with healthcare workers needing to be more thorough, and the idea of educating the public and professionals. And so I've just posed that question of what can we do to improve that.
Healthcare workers are funny people, actually, because when you look at it, we're very scared of something like Ebola, but once you've been a couple of times through a patient, it's also what you hear on the ground from Doctors Without Borders, or even the hospitals in the US or Spain, that once people have gone through the exercise of caring for a patient for some time, we tend to diminish our the doffing and the donning, so we make mistakes because we're not as we don't react as adequate, and so for those kind of procedures you really need somebody supervising yourself, so you don't. On the other hand, as long as you don't have an Ebola case in your hospital, especially here in Europe or the US, I suppose is the same. People are too scared, and it doesn't matter how much you train them, they'll remain scared until they've done it in practice. So it's a thin line to walk. If you try to prepare them too much, they get too scared. If you don't prepare them sufficiently, they make mistakes. I the good balance is actually.
Can we don't start dressing games? We undress people, but we can learn to dress them for giving care to people. A fireman learn this, how to put all the equipment on their shoulders. They have testing training in smoke, not in a fire, but in special houses where they make smoke for testing this firemen. We can also train our caregivers on a regular basis and say, when you don't have fulfilled your training, you lose your diploma.
Oh,
You
well,
have to train
I'm
them.
sure if we do it that way, then a lot of people won't get the training and be very happy to lose their diploma to care for Ebola patients. So what you saw in several of the hospitals in Spain and in the US is that immediately when there's a Ebola case that's been admitted, that your absenteeism goes up dramatically. All of a sudden, everybody is sick and has a reason to stay home. So we count on professionalism of people, and I mean, a lot of the doctors and a lot of the nurses are very professional, and they put themselves out on the line. But in the case of Ebola virus, it's this unknown. I mean, in the case of a fire, you know what you're up against. In the case of Ebola, it's unknown, and people are so scared that you'll find anything to get out of it. There was a very nice report was it in one of the New York newspapers that when one of the possible cases of Ebola, when it was admitted that half of the nurses got sick leave. These are also things you need to take into account.
I am agree. You
No,
can't
one of the things. Go ahead.
pressure someone to give care, but you have to be prepared. You can't say no to training as a doctor. You
Oh
can
no,
say
no, you
no
can't say
by
no to training, and we do sessions in the hospital now. There are dressing for doffing. There are sessions for doffing and donning every day in the hospital. Sometimes the sessions are full. Sometimes there's only one or two persons that are coming. I think so far in other university hospitals in Belgium have trained over 200 people in these procedures. But another thing is, if you talk about these numbers and you start learning people how to dress and undress, one of the limitations that we see now is that for that personal protective equipment, that you have to use a lot of your stock, and we actually can't order anymore. We're out of, I mean, the suppliers can't keep up with demand, and so we have to. That's also something to consider when you give trainings like this. There might be shortages.
One of the things that I've noticed, at least in the circles I'm in here in the United States, when it comes to disaster response, we have a number of different regional disaster exercises. I've been involved in one here in the Southwest U.S. that orchestrated through Department of Defense. FEMA was involved, but the idea was to get federal, state, county, municipal groups all working together in a mock disaster exercise, as well as the NGOs, the non-governmental organizations, so that we're all exchanging business cards and we're learning how to effectively communicate with each other during an exercise rather than waiting for a real event to hit. And there's been some great exercises that I believe all of these different agencies have learned a great deal from. However, I don't believe really enough exercises along the lines of infectious disease, and as a result, I think that's one of the reasons that we've witnessed a number of cases in the United States here of people, just not being well trained on their donning and doffing of PPEs or personal protective equipment, that kind of thing. So I think a lot more could be done, and I believe that, again, going back to my last statement, and I'll quit ringing this bell in a second, but I think it's really important that we do as much as we can right now while this is top of the mind, it's in the media, everyone paying attention to it. Right now is the time to push for not only getting some more emergency exercises put together, but also scheduling those to be done on a sustained basis over time, so that we make sure that we get everybody trained. As far as that whole equation of people not showing up to work when there's an infectious disease outbreak, I don't know. That's a tough one. It might have something to do, if you were working for me, it would have something to do with your next pay raise, I think. But that's just me. I can't pay for one.
Well, indeed, there's actually there's an obligation for healthcare workers to care for. You can be sued if you refuse care to a patient suspected of Ebola. But I mean, it's really a tough nut to crack, that one. Even the hospitals which were best prepared here in Belgium, which had these trainings for many years, now that there was some suspected cases of Ebola in the hospital, everybody could see that people are so scared. I mean, if there's a disaster, big fire, or even we had a train derailment a couple of years ago or last year with a very toxic substance not far from our university hospital, people were flocking to the hospital to help, even if it was cyanide. I mean, it could have killed you in an instant. But people knew what they were up against, they knew what they had to do to protect themselves, and they weren't scared to run away. But infectious diseases, they always give this fear. Look at the pandemic flu, the H1N1 strain that was there. Look at the avian flu. Look at the SARS response, and etc., etc. We are far more afraid of infectious diseases than of a nuclear plant blowing up.
And would you say that that's just a fear of the unknown?
Yeah, it's definitely the fear of the unknown. You don't know the enemy you're up against, and so you really don't know what you have to do. And I was last week in a meeting in Vienna, on the emerging infectious diseases. Was a very good conference. And what struck me is that there was one talk about Ebola, and of course the whole room was filled with all these infectious diseases and epidemiologists and experts from around the world, and everybody was listening very attentively to somebody from Doctors Without Borders, Hilde de Klerk, who's really a hero on Ebola work. And the next session was just on hand hygiene, which is just as important to diminish the spread of infectious diseases. And there you could see, well, I mean, we have very low rates of hand hygiene in our hospitals, but because people know this MRSA, they know these resistant bacteria, they're not afraid of them anymore. And this is where really we need to be better in culling that fear in society and in our healthcare workers to have a better response and to not make the same mistakes as we are doing now. Look at the communication that is happening. You have some very scientific people from CDC who say, or even the European CDC or our authorities who talk about the science, but if I look in the newspapers, what's being printed, and on the other side of the ocean in the USA, it's even much worse, but everybody with a computer can type anything on a blog, get in the mainstream, and the things that sell best are the things with fear.
You know, if I could jump in one more time and just, Stephen, ask you a quick question. One of the things in this think tank that I was involved with, one of the topics that was discussed at pretty significant length was there were some that believed that we need to be doing far more to be training our emergency services people, our paramedics and EMTs out in the field, as to how to effectively respond to some of these kinds of issues, because they are kind of our first line of defense out there, especially in a large-scale thing. Others saying, oh, there's never a reason to involve the fire departments or ambulance personnel. Kind of interested to glean all of your perspective on that. In that, I mean, that when it comes to just about every other form of disaster, those are really kind of our first line of defense. Is there a need? Is there merit to the idea of increased focus on training for those first responders for infectious disease concerns, or is that really out of the scope of what we need to be thinking of?
Well, you have to put yourself in the skin of an emergency nurse, a triage nurse, or emergency disease physician. You're trained to save people, and so you're trained to diagnose that heart attack, or you're trained to diagnose that disease that might kill your patient. You're not trained to protect society from the next pandemic, although things like that come through your doors, whether it's a new disease like the SARS, or whether it's Ebola. And so I don't think that training emergency disease physicians as such would help a lot, but what does help a lot, I think, is that having an infectious disease specialist or hospital hygiene specialist that keeps abreast of these things and can warn people on the emergency department, okay, this week the Hajj, or I mean in October somewhere the Hajj finished. We know there's MERS coronavirus in Mecca, so this week please be looking out for people with pneumonia. Think about the MERS. Or with the Ebola, I think that the emergency departments should get help from somebody which is knowledgeable about these diseases. Protecting yourself against Ebola or response against Ebola, it's really common sense. It's the universal precautions you have to take, which will prevent the spread to you or to other patients in your hospital or to society. But common sense doesn't help when you don't ask the right questions, and you're only going to ask the right questions when you're prone to it. See, what happened to the patient in Dallas, he came to the emergency room. He was asked by the nurse, I think, whether, I mean, he had fever. He didn't volunteer the information that he came from West Africa, but somewhere it came up, and it was in the electronic health record of that patient, but it wasn't transmitted to the physician attending him, so he got discharged from the hospital. He wasn't picked up by the system. Now, if you have somebody in the hospital that says, you know, guys, you have to look out for this, and this is what you 5 simple steps to protect yourself, or whatever, I think that might have a bigger impact than prepare or train everybody in tempo non suspecte in epidemic times. So it's probably best to have somebody that follows it. And like in our hospital, I follow all the mails. I follow all the international soundboards where a new infectious disease is coming, and people know, like intensive care, if they see something strange, they call me. Have you heard anything from that region or whatever? Which is far more effective in picking up things.
We've had a very interesting discussion, and we are past the top of the hour, so we should probably wrap up this discussion, but I know that there has been some requests for more than just this hangout, so perhaps we can meet again and have some additional guests and continue the conversation and vary our topics a little bit the next time. Are there any last words that any of you would like to make before we close out this hangout discussion?
Well, I do apologize. I wasn't there for the whole time, but I really tried, really.
I know you did. We appreciate you making it. Ludwig, did you want to say something?
I was very pleased with this discussion, and I want to have another one in the future because I think using this platform can help everyone.
I do think this is an excellent vehicle for discussion and getting new insights and maybe even some ideas that we don't even know are out there, because this kind of conversation can really bring light to someone's idea that wouldn't otherwise have a chance to have a voice. I do want to, just for a moment, thank a couple of people who worked behind the scenes. Maurice Einhorn from, let's see, what was his title? He is a doctor and online health media professional in Belgium. And also Gianfranco, help me with the last name. Gianfranco, come on, help me. Ferrandini, I think I said his right now. He's an independent consumer services professional. Both of them helped with some of the acts that we made over the week and getting information out and being a general support system. So I thank them, and I especially would like to thank the guests that I've had today. So Ludwig, thank you for making this happen and for lighting a fire under me to get this going. And Randy Roberson for being a participant and bringing your wonderful expertise and information from the recent think tank. And Dr. Callens for, Dr. Callens for joining us and for fighting through the subway fires to join us. And I hope that we'll have some more discussion soon. So I will conclude today's hangout discussion on Ebola containment. I'm Kathy Brown of Brown Nose Social Media. Thank you for watching, and if you'd like to share this video, it is automatically on recorded form on YouTube after it's played back. If you can't find it, you can always reach me directly at Kathy Brown on Google+, and I'll be happy to send you the direct links. Have a good day.